Hello, everybody. Sorry, they had changed the format and it took me a second to get on. Hold on one second here. Nice to see all of you. My name is Brooke Rossi, and I am a reproductive endocrinologist and infertility specialist at Ohio Reproductive Medicine. And I will be talking again tonight about some infertility topics. When we met probably, I don't know, about 6 weeks ago when we talked about some kind of general infertility questions. And today we thought we would focus a little bit more on in vitro fertilization. And of course, at any point, please ask questions along the way. You can use the little text message thing to send us a question, and I'll try to keep track and answer your questions as well. But let's kind of start by talking about in vitro fertilization, or IVF. And before we even start that, actually, I just wanted to mention that this is a really hard time of year for our patients with infertility. With the holiday season is very much focused on children and babies and kids, and a lot of our patients have to see family, and very well-meaning family members are come up to you and ask you when you're going to have a baby, and they have no idea you've been trying for 2 years. So I just wanted to acknowledge that it's okay to feel maybe more frustrated or upset or sad this time of year. It's okay to ask for help or support from support people more this time of year. And it's also okay to say no to things this time of year. So if your friend invited you to some party and you just know a bunch of kids are going to be there and you don't want to go, you don't have to go. So just take care of yourself kind of over the next month or so, because this can be a kind of tricky time of year. So, all right. It's funny, we spent a lot of time talking about IVF, and it's something that we could talk about within probably a couple minutes. And then in preparing for this talk, I wrote a really long list of things that we could talk about. So if we don't get done with it all in one time, we'll just talk about the rest of it next time. But one of the first things that I wanted to talk about was the preparation of IVF. And a lot of times patients will ask, maybe they're doing some other type of infertility treatment like insemination, or maybe they just found out that they need to do IVF because of some other health issue. They often want to know how fast can I do it, or how long does it take to get ready? And that varies from clinic to clinic. There are some things that need to get accomplished before you can do IVF, including things like getting authorization from your insurance in case you have insurance coverage, getting medications. The medications that we use for IVF, in a lot of places only come from mail order pharmacies, and it takes a couple weeks to get them. We have to teach patients how to use the medications, because the medications used for IVF, many of them are injectable medications, and people might not have had any experience with those before. Oftentimes there's other testing that your physician may want to do before the IVF cycle, such as doing a uterine evaluation, or doing something called either a uterine sounding or a mock embryo transfer to know the pathway into the uterus when it's time to put the embryo in. You may have residual carrier screening, genetic carrier screening that needs to be done, or updated your ovarian reserve. So in our practice, it takes about a month to get all of that done. And that's okay. I mean, that also gives patients sometimes a well-deserved break before they jump in and do IVF. And this is just my personal preference. I mean, you can do IVF, whenever you want, but I think it's a good idea to do IVF when maybe it's not like a super busy time at work, or there's not a lot of stress in your life, if you have any control over that kind of stuff, because it's a lot of work, and it's doctor's appointments, and you just want to make sure that you are, you have all your energy to kind of focus on IVF, and don't have a lot of other things you have to worry about at that time, if possible. Obviously, there's people from all walks of life that do IVF whenever they need to. So once you have the preparation done, one of the other things that your doctor will do will also think about a protocol for you. So I want to talk a little bit about IVF protocols, because this can be a question for a lot of patients. One of the things that we really focus on when we think about a protocol, so a protocol is what are the medicines or the hormones that you're going to be taking during IVF to help your ovaries make several eggs at once, and what way will you take them? What are the doses? How many times a day will you take them? What other medications will you take in addition to the medicines to make the eggs grow in the ovaries? One of the main pieces of information we use to help figure out the protocol that somebody uses is their ovarian reserve. And ovarian reserve is this idea about the quantity and the quality of the eggs that you have left. And it can be assessed by a couple different ways. So one way is with something called an antral follicle count, which is an ultrasound that's done in the first few days of the menstrual cycle to look at the ovaries and count what we call antral follicles, which are the very small follicles in the ovary. We also may do something called an anti-Müllerian hormone level or an AMH level. We also may do a day 3 FSH or an estradiol. And those are kind of the main bits of information we use to look at somebody's ovarian reserve. And that ovarian reserve, primarily the anti-Müllerian hormone level or the AMH, will help us understand how many eggs you may get with an IVF cycle, or how many eggs you may get with other women, similar to your age, and how much medicine you may need. So, for example, someone with a lower AMH level might need more medicine to get the same amount of eggs as somebody, with a overall normal AMH level. And then in general, we have different protocols. So we have, kind of medication protocols that we tend to use with patients who we think might have a greater stimulation or have higher ovarian reserve. We have protocols for women who are what we expect to be kind of normal responders. And then we have protocols for women who we think might be making less eggs than other women their same age. And, unfortunately, I wish that all the patients came with a little instruction manual, but they don't. And so sometimes we will try a protocol and we'll do our best based on, the research and our experience to pick the best protocol for somebody. But sometimes it can be that that's not the best protocol, that they may have done better with a different protocol. Or sometimes we'll see someone who maybe has done an IVF cycle in a different practice, and we will use that information to try to modify the cycle and make it better to help with maybe how many eggs the patient gets or embryo quality. And there are a couple different medications that we use. Primarily, you're using some form of follicle-stimulating hormone, and some of the trade names for that are Follistim or Gonal-F. Then you will also sometimes use some medication or hormonal medication that also has luteinizing hormone in it, or HCG in it. So the name that we use for that is called Menopur. And then sometimes patients will also have something called an antagonist, depending on the type of protocol that they're on. And that prevents the patient from ovulating before it's time to collect the eggs. And some patients will also use a medication called Lupron, and you can use Lupron in a couple different ways to sometimes to help encourage the ovaries to make more than one egg. And the Lupron also works to help prevent ovulation until it's time to retrieve the eggs. Hold on just one second. I'm just going to, so we've talked about the stimulation. I just want to answer a question that one of the viewers have posted about the COVID vaccine. Maybe this is a good time to talk about this because, as you know, COVID is still out there, and we're currently trying to figure out if there's another potential wave coming. I think it's really important for our patients to understand that we would never do anything or suggest anything to our patients that would hurt them or hurt their chances of getting pregnant or cause them to have a miscarriage or hurt their baby or anything like that. And we are only trying to help women stay healthy and have healthy pregnancies. And so it is important that everybody get the vaccine if possible, and then consider getting a booster as well. And so it is safe to get the COVID vaccine during pregnancy. It's safe to get it while you're trying. It's safe to get it really anytime. So I would encourage patients to get it. And I know it can be a kind of a scary thing for women who are trying to get pregnant or maybe who are pregnant. So I would encourage you to talk with your doctors if you have any questions. But it definitely is safe. And these are guidelines from every Women's Health Organization, the American Society for Reproductive Medicine, the High Risk OBGYN Association. So I would definitely recommend getting the COVID vaccine pretty much whenever you can, as long as you're eligible for the booster. So we were talking a little bit about the different protocols, and so this can be kind of tricky because I think that sometimes patients talk a little bit about what protocol they're on, or they hear people talking about different things, and we do usually have a little bit of a method to the madness when we create your protocol. And if you ever have questions about it, and there's a lot of other things sometimes that get added to IVF protocols that there may not be a lot of data on or a lot of research on, and sometimes those things might not hurt anything. Sometimes they might not help anything either. And if that's something that you're interested in, you can always talk to your doctor about what they think is reasonable and whether that should be part of something you could incorporate into your protocol as well. There is a question about fibroids, and the question says, what is the best treatment for intramural fibroids and fibroids outside the uterus in a patient who wants to get pregnant? Fibroids are really tricky, I think, for patients who are trying to get pregnant, because we often are trying to do as little as possible with these fibroids, and having a fibroid surgery, depending on where the fibroids are, can be a pretty significant surgery. If the fibroids are really in the center of the uterus, like in the cavity, sometimes they can be removed with a more simple surgery called a hysteroscopy or hysteroscopic myomectomy, and there isn't any incisions on the abdomen or through the wall of the uterus. But if a patient has something called an intramural fibroid, which means that the fibroid is in the actual wall of the uterus, really the only way to remove that would be by making a cut in the wall of the uterus and removing the fibroid, and then carefully sewing up that fibroid, sewing up the uterus to make sure that the uterus is nice and strong and can tolerate the stress of a pregnancy. And so depending on where it is and depending on the access patients have to different types of surgeons, it is often reasonable to consider doing what we call a minimally invasive myomectomy, which may be with a laparoscopy or maybe with even a robotic myomectomy, and because that can help limit the amount of recovery that you need off work after the surgery. It can also decrease scarring after a myomectomy. So if that's something that's available, that's always a good option. Sometimes though patients have many fibroids, or the best way to really get it out is to do what we call an open myomectomy, which is with an incision. So it really just depends on the amount of fibroids that are there, where they are, and sort of if there's a doctor in the community that can perform a minimally invasive myomectomy. And I am just looking here. I'm looking at some of the questions. Oh, actually, somebody asked a great question, and I wanted to bring this up when we thought about the protocols. So there is something called batching, and what that means is when an IVF center might not have their lab open all the time, and this is more true of kind of maybe of smaller IVF centers. And so what they'll do is they'll try to have all their patients do an IVF cycle in the same week or so. And sometimes to be able to do that, patients need to be put on birth control pills so that they all kind of get lined up and so they can all have their retrievals at the same time. Sometimes birth control pills can also be used for other reasons before IVF, sometimes to if they have endometriosis, or sometimes if they have PCOS. And most of the data on using birth control pills from IVF doesn't show that it's particularly helpful, meaning like it doesn't seem beneficial to patients. Most of the time it doesn't show like it hurts anything either. And so, if your doctor says, oh, we really think you need to be on, these birth control pills before you do IVF because we don't do IVF until, the middle of the month, that's usually okay. I wouldn't want anyone to think that they're at a disadvantage because of that. That doesn't seem to be a major issue. Just At our practice, we don't do that as often because we don't batch our cycles. So we don't have a lot of patients on birth control pills. But again, there's a lot of clinics out there that do, and the pregnancy rates are just as good as anywhere else. And so it's totally acceptable. All right, and we were talking a little bit more, so we had talked about the different protocols, and so some of their names are antagonist protocol, you have a microdose Lupron protocol, a Lupron downregulation protocol, sometimes people use Clomid or Letrozole with the gonadotropins. The gonadotropins are the FSH and the rest of the hormones that we use all together. And essentially an IVF protocol, what you're doing is you're trying to, because you remember the body only wants to make one egg per month, okay? And so with IVF, what we're trying to do is to make several eggs all at once and not really as many as possible, right? The goal is to not make as many eggs as possible. The goal is to make a good number of good quality eggs. And so we try to get all the eggs to grow up at once, but then you have to also prevent ovulation so that the eggs don't start to be released before the actual egg retrieval. And that is what the Lupron is for. That is what the antagonists are for. Okay, so what will happen with a patient is they will, they'll get their cycle all ready. They have their protocol. They have their medications. They have their calendar. They have everything they need. They start their period, and they come in for a baseline ultrasound. The point of the baseline ultrasound is to make sure that the ovaries are in the right phase of their cycle and that they are receptive to the medicines we're going to give them. And so usually, patients always come in, we know that you're having your period for the baseline ultrasound. That's okay. That's the whole point. So you'll have your ultrasound, and we usually want, if the estrogen is being checked, we want the estrogen to be low, and we want to make sure that there's no significant cysts on the ovaries. And sometimes there's a little bit of flexibility with that. It kind of depends on sort of the whole clinical picture for each patient. But as long as patients, pass the baseline, meaning that everything looks good on their ultrasound and their blood work, they will then begin the ovarian stimulation. So that's like kind of the hard work for the IVF cycle for the patient. And so patients will take medication every day. And it might be for anywhere from, 8 to 12 days or so. Some patients take medications once a day. Sometimes patients take medications twice a day. Sometimes they're taking 3 or 4 different types of medication. It all just depends on the protocol. And the medications that are used in this part of the cycle, for the most part, are what we call subcutaneous. So they are injections usually in the abdomen and with a small needle. I think that the idea of taking injectable medications for patients is kind of scary when they first start to think about it. But I always try to remind patients that, we have patients from all walks of life that come to do IVF, and everybody rises to the occasion. They all figure out how to do it. Sometimes they have friends, partners, families, members, whoever help them out and do it. But people can get this done really well, and they do great. And people are always nervous also about the side effects from, doing IVF or from this process. And I don't know, people usually feel okay when they do it. I actually find that people complain more about taking Clomid and Letrozole and how those give people side effects than they do about the actual, gonadotropins. The gonadotropins are, again, the injectable medicines. But anyway, so basically what happens is the patients are taking the medicines every day, and then they're coming in for evaluation to check their progress. And so these are we call them monitoring scans here. So, patients may take, 2 to 4 days of medication and then come in for an ultrasound and an estrogen level so that we can check their progress. And sometimes patients may have other hormones checked as well. And so you may have, 3 or 4 or 5 monitoring scans within the window that you're doing your shots of medicine. And really what we're trying to do, kind of 2 things. One, we're trying to make sure that we have you on an appropriate dose, meaning that we have an idea of where we want how we want the follicles to be growing and what we want the estradiol or estrogen level to be. And so sometimes we'll give patients a little bit more medication if we think that maybe their follicles aren't growing fast enough. Sometimes we'll give patients less medicine if we think things are happening too fast or they're making too many eggs. The other thing we're checking is we're trying to see when the eggs will be mature. Because when the eggs are mature, that's when we want to do the egg retrieval to take them. And so, again, that process of the ovarian stimulation, I don't know, on average probably takes about 11 days. Okay, so you've taken all the medicine, and then we have to get the eggs. And so this is an important part of the IVF cycle, and this is, we call this the trigger shot. And essentially what needs to happen is, we're working really hard to get the eggs to grow, but then the eggs have to be mature, and we have to be able to get them. And so the medication that does that, there's two different medications that we use. Naturally in the body, this is caused by luteinizing hormone. So you've probably heard about an LH surge. That's what causes the eggs to finish their chromosomal maturation and also allows them to be released from the ovary. And so when we're doing IVF, there are two different medications that we use to help trigger or mature the follicles. One is often it's actually a shot of HCG hormone or pregnancy hormone. And then the other thing that we often use is something called Lupron. You may have a Lupron-only trigger, and sometimes you may do a combination of both, okay? And only patients who have not been on Lupron at any other point in the cycle are the patients who can do a Lupron-only trigger. And it's often our patients who we have maybe some concerns about a risk of ovarian hyperstimulation. Those are the patients that tend to use the Lupron-only trigger, okay? And so we do the trigger, and then most patients will then have their retrieval done 36 hours from when they've had the trigger shot. And that, we kind of are we're kind of a pain in IVF, the doctors and nurses and staff, because we are we are strict with a lot of things, and this is something that we really can't mess around with, which is the time that you take the trigger shot and then the time we do the retrieval, because if the timing gets wrong or it's late or whatever, sometimes the eggs will be prematurely ovulated and we can't get them. And so we want to be really careful about the timing of the trigger and doing the retrieval and everything. So we had a question about doing a retrieval at the same time as a myomectomy. And that would be a wonderful thing if we could do multiple surgeries at once, but we can't. Mostly, there's probably two reasons why we can't really do that. One is logistically it would be nearly impossible to try to schedule a myomectomy because we don't really know that, with the egg retrieval, this is always kind of hard for patients too, because we don't, we don't know exactly the day you're going to have we have an idea of when the retrieval is going to happen, but we don't know exactly the day until it gets closer. And then I think trying to do a myomectomy, the ovaries kind of get so big that they would be in the way, quite frankly, of trying to do the myomectomy. And so that's a good question though, because some patients, depending on maybe their overall treatment plan and their age and the significance, what type of myomectomy they're having, sometimes we will have patients do IVF and bank the embryos and save them, because sometimes patients need sometimes up to 6 months to let their uterus heal after having a myomectomy. So sometimes we'll say, yes, we know the fibroids are there, yes, they're in the way, but let's go ahead and get our eggs and create embryos. And then while you're, then we'll let you heal, and then you'll use those embryos down the road. It's kind of like a form of fertility preservation, actually. However, sometimes people's fibroids might be so big that we actually can't get to the ovaries. So sometimes we'll do the myomectomy while the patient's healing, then go and do the IVF cycle, and then let them recover, and then do a frozen embryo transfer. So long story short, there is a lot of different ways that this can be done, depending on sort of what each patient's clinical picture is. So let's talk a little bit about the, I just want to make sure there wasn't anything I forgot to add here. let's talk a little bit about the egg retrieval. And so I was going to try to, hold on a second. If anybody joined our last Facebook Live, at some point I pull out the dry erase board, so sorry about that. But I feel like I might need to just do that again so I can show you guys what I'm trying to talk about here. Because I think that it's kind of hard to understand how we actually do the egg retrieval. So I'm gonna try to show you here with a really bad picture. So hold on. I kind of feel like Mr. Rogers or something when I do this. All right. Although he was probably had a better thing here going on. All right, so if we look here, this is the uterus and these are the ovaries. And so remember, things are very different when you're going through an IVF cycle. And the ovaries, when they get big and enlarged, they kind of fall a little bit into the pelvis. And if you think about how most patients are kind of built here, this is the ultrasound probe. And we actually use, so the procedure technically is called a transvaginal ultrasound guided egg retrieval, okay? So what that means is, if this is the ultrasound probe, we have a needle and it goes right through the wall of the vagina into the ovary, and then we drain the follicles. Okay, so let me explain that a little bit more. We can very easily just use the needle and go through the wall of the vagina, and then we go into the follicle. And patients are usually asleep for this procedure, so they usually don't have any pain during it. And so then we remove the fluid that has grown in the follicles, and then we, with very careful suction, this little like suction pump that's attached to the needle, and then we actually hand the fluid then to an embryologist. And one of our embryologists will then look at that fluid underneath a microscope, and they look for the eggs. And then we just literally go through each follicle, drain the fluid, go to the next follicle, drain the fluid, go to the next follicle, drain the fluid. And then we're handing the fluid to the embryologist. And then the embryologist let us know when they're finding the eggs. The egg retrieval, depending, kind of, how long the egg retrieval takes, kind of depends on how many follicles a person has, but usually it's done, I don't know, in anywhere like 10 to 25 minutes. It's an overall very, very safe procedure. The risk of getting a complication from the egg retrieval, like an infection or bleeding or damage to like one of the organs nearby, like the bladder or the bowel, it's very low, probably less than a 1% risk of having an issue with the retrieval. Most patients don't work the day of the retrieval. Most patients can go to work after, like the next day. You feel like you had something done to you. You don't probably feel like you want to jump up and down and, go on a treadmill or anything, but people, can go to work and kind of do the things that they normally do after an egg retrieval. I'm just going to take a break from talking about the egg retrieval for a second to look at some of the questions that we're getting in. So one of the viewers asked a question about patients with polycystic ovary syndrome. And, polycystic ovary syndrome is a really common condition. It's considered one of the most common hormonal issues among reproductive aged women. Like 7% of the population has it, which might not seem like a lot, but that's a lot of women. And so, one of the biggest challenges of working with PCOS is making sure that somebody recognizes that you have it. So it definitely, if you have questions, if you have PCOS, and if it feels like people aren't really listening to you, or it feels like maybe, you've read about it on the internet and you think you have it and you have concerns, so definitely find, a clinician that will talk with you about whether you have it or not. Because if we can find the patients with PCOS, a lot of them, we just need to get them on appropriate medicines to help with something called ovulation induction, which is helping them ovulate. And often the medications that we use for that, they're not fancy, they're not expensive, they're just pills. And if we can get people on them and get them ovulating, as long as there aren't any other significant fertility issues, a lot of times those patients can be pregnant within 6 months. So we do have a lot of success with patients with PCOS. Now, obviously, sometimes those patients need more invasive treatments, but a lot of them can get pregnant with simple medications too. I have actually a really big interest in kind of lifestyle issues and IVF, and one of the viewers had asked the question about dietary changes. The data and the studies about like what people should eat. There are some. I think there's books out there about this. I think you just kind of need to be thoughtful and kind of smart about it. I think that everyone should probably try to, limit alcohol or not drink alcohol as they're doing this. I think probably limiting sugar is not a bad idea. Making sure you're taking your prenatal vitamins is definitely something that you could consider. This is a little anecdotal on my part. So again, there's not a ton of data on this or anything, but sometimes our patients with endometriosis, I think if they know that there's foods that really bother them and cause them to have more pain, it's probably causing them to have more inflammation also. So sometimes I've had some endometriosis patients feel significantly better by modifying their diet, maybe watching things like gluten and sugar and dairy. And, I figure if they're feeling better, that's probably helping with their inflammation, and that probably is not a bad thing. So I think you want to just be careful about kind of the things you're eating, as you're doing infertility treatment. And then we have a question about a little bit more about endometriosis. So endometriosis is when it's also one of the most common conditions with infertility too. And it's when the lining of the uterus kind of ends up, the cells that are usually in the uterus end up in other parts of the pelvis, and they can be on the fallopian tubes, they can be in the ovary or in the ovarian cysts, and they can be, around the pelvis, and they can cause inflammation, cause scarring, and make it hard to conceive. And so IVF has a very big role in patients who have endometriosis, and it's definitely not that every patient with endometriosis needs to do IVF, but there is a role. So, sometimes patients either wonder if they have endometriosis or were told they have endometriosis by a prior surgery. If your fallopian tubes are open and, and there aren't any big cysts on the ovaries and you're feeling okay, maybe somebody would consider doing some inseminations first. It's often when people aren't getting pregnant with the insemination, or they have a big ovarian cyst, or they're kind of at this crossroads where they're thinking about doing IVF or surgery for endometriosis. Sometimes those patients will consider doing IVF because it may be that gives them a higher chance of getting pregnant than doing surgery for endometriosis, and could be less medically risky, just considering the risk of doing a surgery. So, and then I have a question from another viewer about the success rate on a first IUI. So it kind of depends on, the chance of getting pregnant with an IUI kind of depends on what else you're doing with the IUI, meaning like, was the patient doing oral medications like Clomid or Letrozole, or was the patient doing fertility shots like gonadotropins and doing IUI, what her age is, all that stuff. Kind of depending on the scenario. I mean, if you're, kind of a patient with unexplained infertility who's doing Clomid and IUI, your chance, is probably somewhere between like 7 to 10% each time you're doing an IUI, first time or third time. The caveat with that is that you have to remember, because that always sounds really low, like when I say, oh, we're going to do IUI and your chance is 10%, people I think always look a little disappointed. But you have to remember, if we're looking at a per month success rate, okay, if we took like fertile people and looked at their chance of getting pregnant each month, their chance of getting pregnant and having a baby each month is probably only about 20%. And if we looked at a patient who had tried for a year, if they're less than 35, tried for a year to get pregnant and wasn't getting pregnant, their chance of getting pregnant each month is less than 1% or 1%. So 1% is where the patients often start with, 20% is normal, so 10% is not that bad if you kind of think about it like that, okay? All right, I'm just looking back to see. Hopefully I've gotten it, you guys are getting our answers okay. So we have a question about secondary unexplained infertility. So secondary infertility means that the patient has gotten pregnant in the past. So primary infertility is infertility in a woman who has never gotten pregnant before. Doesn't mean she necessarily had a baby, but she has at least conceived in the past. And then secondary infertility is when a patient has conceived but can't get pregnant a subsequent time. And that's really frustrating for everybody. I mean, it's really frustrating for the patients. It's really frustrating for us. And you kind of have to stop and be like, okay, it kind of takes a little bit of detective work to try to figure out. This is especially difficult in people who had no trouble getting pregnant the first time, and then all of a sudden they're having trouble getting pregnant the second time. So it does take some work to try to figure out, okay, sometimes it's because patients are older than they were when they had gotten pregnant the first time, or maybe something happened to them when they had their baby. Maybe they had a complicated C-section and had scarring, or maybe they have a new health issue, or maybe their weight's significantly higher, or maybe there's an issue with their partner, that, maybe if they have a male partner, he needs to have a semen analysis done. So it's worthwhile kind of seeing a doctor or a clinician and trying to go through the history really carefully to see if anything's jumping out. Things happen. People get thyroid disease. People, have things that come up that can change their health, that can make it harder to get pregnant a second time. And so depending on sort of how patients come to be with their treatment, if there was no new thing that happened, because a viewer asked if there was less success with IUI or IVF if patient has secondary infertility. Not necessarily if as long as you don't account for things like maybe they're 4 years older or that sort of thing. The treatments really should work about the same in either situation. I want to talk about one more area of IVF that I think is kind of always a question that people have, so I just want to talk about it. I want to talk about when and how to do the embryo transfer, okay? Because this is a topic that patients always have questions on. And what I'm talking about is, why would we do a day 3 or a day 5 embryo transfer? And why would we ever want to do a fresh or frozen embryo transfer? So let's talk, and this might be kind of the last kind of big topic we talk about tonight. Let's talk about fresh or frozen first. So what we're talking about, so a fresh transfer is when you do the whole ovarian stimulation, the egg retrieval, and then a few days later you have the embryo put into your body. So it all happens in the same month. That's called a fresh embryo transfer. A frozen embryo transfer is when the IVF cycle happens, the embryos are created, and then in a subsequent month, it might be 1 month later, it might be 5 years later, that embryo is thawed and then put into the body, okay? So right now, with how most people around the country and the world are freezing embryos, the chance of getting pregnant if we kind of just start at baseline, we know that the chance of getting pregnant with a fresh and a frozen embryo transfer are about the same, okay? However, there are some scenarios where you may actually have a lower chance of getting pregnant with a fresh than with a frozen, okay? And so some of those things that we may find may be, if patients who overstimulate have a lower chance of getting pregnant with a fresh transfer. Patients who may have an elevated progesterone level during their IVF cycle may have a lower chance of getting pregnant with a fresh compared with a frozen. So we can kind of say fresh and frozen equals the same unless one of those issues happen, which is why sometimes we will encourage patients to proceed with a frozen transfer instead of a fresh. The other thing I want to mention is a day 3 or day 5 embryo transfer. So this is kind of let me say this is kind of like a historical thing, because people used to always put embryos back on day 3. And then as the laboratories got better and IVF got better, people started to be able to grow embryos out for longer. And we were able to then have higher pregnancy rates because the embryos were a couple more days developed before we put them into the body. And really what's happening between day 3 and day 5 is that the embryos are kind of selecting themselves. So for example, let's say you started out on day 1 with 10 embryos, okay? On day 3, you might have 6 embryos. And on day 5, you might have 4 embryos. And it's because not every embryo grows all the way. A lot of them don't make it. And some of them kind of select themselves out. They just stop growing. And so when you grow a little bit longer to day 5, they kind of prove to us who are the strongest ones, okay? So there are some IVF centers in the country that only do day 5 embryo transfers. And their kind of belief is, well, if it's going to make it to day 5, it's going to be good. And other than that, they're not good embryos. And some people think differently. Some people think, well, if you put an embryo in the body on day 3, it's going to be better in the body than in the laboratory. So put it in on day 3. And then some people kind of fall in between. And so whether a patient has a day 3 or day 5 embryo transfer sometimes depends on things like what their overall, how many eggs they got and how many embryos they had. It sometimes depends on their age and how many eggs and embryos they have, and kind of the style of either their doctor or the clinic. And so it's neither one. I mean, the American Society for Reproductive Medicine has guidelines sort of for if patients were doing a day 3 transfer or a day 5 transfer, how many embryos, they would have. People tend sometimes to get more embryos used on day 3 than on day 5, just because there's a little lower chance of getting pregnant on day 3. To compensate for that, people have more embryos put in. And maybe I should say the reverse. Actually, you have less embryos put in on day 5, which has been nice because it's allowed us to lower the risk of having multiple gestations. So fresh and frozen. If your doctor says, hey, we need to do a frozen embryo transfer, you should have the same chance, if not better, of getting pregnant than with the fresh. It's kind of disappointing a lot for patients because they may have to wait a month, but usually if your doctor is telling you that, it's for a good reason. And so I wouldn't want anyone to worry that they're going to have a lower chance of getting pregnant if they had to have a frozen embryo. And then, if you have thoughts about whether you should have a day 3 or day 5 embryo transfer, just talk to your doctor about it. And there's probably, a reason why they feel strongly one way or another. So, but either one, it gives you a good chance of having a baby. Anyways, I think that we're about running out of time, and I really appreciate all of you joining us today. And, I'm always happy to do this again, and if there's different topics or questions you want to talk about, we can always talk about them again in the future. And if you have any questions, you can always reach out to us on either our Instagram page or our Facebook page. And I really appreciate you all joining us tonight. I hope you're taking care of yourselves and have a wonderful holiday season, and we'll have a great 2022. So we will talk with you soon. Thank you so much for joining us.